joining as we go over the next few minutes. Yeah, just a reminder, Louise is recording the session, so thank you for allowing us to record it. So if people want to watch again or unable to make the whole meeting and want to watch on playback, the recordings are stored on Stafford Training Hub website. Also, you might have seen right at the beginning some of our promotional slides. They'll be running again at the break that we have. It's just a bit of a shout out for one that I'm involved in. So for about 5-6 years, we've offered coaching and mentoring for GPs across the county, wherever you are in your career. And we've recently increased the offer to any person working in primary care workforce. So there's a multi-professional coaching and mentoring offer. So all the coaches and mentors have had extra training, and there is now some non-GPs that have been trained as coaches and mentors for the scheme. So I welcome you all to have a look at that. Feel free to contact me if you want any more details, but some of your team members, practice managers, nurses are also now able to take up the offer for coaching and mentoring. And there's also another promotional slide about wellbeing resources, which again I'm very passionate about, and just take a look at that. There's lots of really good resources we've got on our website to support primary care staff at this time. So I will get on with today's PLT. So welcome everybody. As you know, we're concentrating on frailty today. So we've take as normal protocol, we'll have a first speaker, and then we'll have a short comfort break, and then we'll have our next speaker. So our first speaker today, I'd like a really warm welcome for Dr. Bushra Gori, who's a consultant in acute and geriatric medicine, and she's going to be talking to us about the complexity of prescribing in frailty in primary care and supporting us in practical decision making. So thank you very much for joining us, Dr. Gori, and I'll send this over to you to carry on. Thank you.
Thank you, Donna. So, as you know, I just work in a Mid Yorkshire hospital as acute consultant and geriatric medicine consultant as well. And my main work is around frailty, falls, syncope, and also geriatric osteoporosis. So this is all bit that I usually cover. I usually have dedicated team for assessments of these falls and frailty in the community as well, that I run through the MDTs as well. So let's see with a quick overview how things change over the decade from frailty to up to now, where we are dealing with this complex syndrome. So we'll run through with a brief introduction, then finding out how we actually identified frailty, what is the difference between the frail patient prescribing and the other normal patients as well, and especially the young patients. And we'll run through with some of the cases that you can actually see how things change with the frailty, prescribing, stop-start calculator, and some of the other medication that we normally consider about. And then few take-home points for the learning as well. So what is frailty? There are different. Okay, can you not hear me very clearly? Is it clear now?
Yes, if you just lean towards your microphone, I think that would be helpful, please. Yeah, it's going a bit quiet at times. Thank you.
Okay. So hopefully we just have. Can you hear me more better now?
Yes, that's better.
Yeah, much better.
Thank you.
That's fine. Sorry about that. So basically just a couple of things that we always think about what is actually frailty. Sometimes it is very vague concept for some of the people around, not related to health professionals. And sometimes people do think it's just end of life care basically. And we are stopping everything because it's just the life is finishing and this is the terminal stage. And sometimes people do think about how physically the patient looks like, and this is actually frailty. but actually it is a lot different. Sometimes we have longer discussions with the family and their relatives about what exactly the guidelines are different for a frail patient and for the young patients, especially in prescribing. Sometimes it really helps in understanding and the MDT discussions with the families and the patient as well. And it's actually thinking of it's not only part of aging, but it is actually something more that we have to improve and prevent. So definitions from 2014 with the Professor Clegg, when I worked with him in Bradford Royal Infirmary, it was a time when it was electronic frailty index was actually starting, and we were in the process of discussions about a lot in these things. So it is multiple interrelated physiological systems that actually implicate about the frailty, and then accelerated decline in the physiological reserve and the hemostatic mechanisms when it fails. So from there up to like 2023 in BGS, it's the about how increased vulnerability to the poor resolution of hemostasis after a stressor event, and especially as a consequence of a cumulative decline in multiple physiological systems. So we can think about how things change when even like a simple stressor, simple injury, or simple illness can actually impact hugely on these frail patients. So technically, when we say it is basically the same definition that we think about, but it is like in broader spectrum with reduced resilience and especially decompensation. And then simply that we say when small things or more things that are going wrong, even minor things can give them increased risk of severe outcomes, especially because of the accumulation in the deficits. So what actually we are facing for these frail patients is they will likely end up more hospitalization, increasing mortality, increasing longer time of their stay in the hospital, then hospital complicated infections, and then they end up in institutionalizations as well, like whether it is short term or sometimes it is long term care home, and then they die earlier as well. So with this graph, easily you can see when even like a small illness that happens in a fit older person, they can actually dip down, and then definitely with the green line that you can see, they can go back into their fully independent life as they were before. But for a frail patient, you can see that the small illness, even like a small stress factor, they can actually have severe loss in their normal dependence and then normal independency, and then they dependent on a lot of other activities of their living as well. So it is a huge difference. So we commonly see these frailty syndrome like in the hospital that with the deliriums, recurrent falls, and also especially you guys also see in your community as well with the immobility effects and the medication adverse outcomes as well, and incontinence issues that are very common with these frail patients as well. So how do we normally assess? These are the common ones: that time up and go test, electronic frailty index, and then clinical frailty score that as per rapid that we normally use in the hospital. So time up and go test, if you have seen, it is very simple and very effective, and it gives you an idea of their gait, their speed of walking, their dependency, and how much they're actually prone to having falls, or if they are actually falling, what is actually their score. So in the clinic, normally in the falls clinic, especially when I usually see the patient, I always do the time up and go test if they are able to walk few steps. So going and coming back in 3 meters time, turning, how they are turning, how much actually they are taking the time. So it is very important for us to assess them for the gait assessment and the gait speed. Electronic frailty index that we will speak for these ones, that is very common that we normally see 36 conditions of the life that are actually there with 26, with only 20 diseases, and then 7 disabilities that are very important. So even simple things like anemia that also contribute in EFI as well. So there's a huge list as per Dr. Prof. Clegg that actually has published in Age and Aging in 2016. So since then, we are actually facing these common ones as with the prescribing is with the polypharmacy, especially then dizziness episodes, falls, dyspnea, incontinence issues, memory and cognition issues. Then there is a huge list of all these problems that actually you see every day as well in your own settings. So the common theme and the common key is about comprehensive geriatric assessment. That is very important, and how actually you can do in your primary care setup as well, like routine reviews about the frailty, about the long-term catheters. Then in the home visits, geriatric assessment is easy, but sometimes it's hard, and you can always refer for the geriatric assessment clinics and the frailty teams in the community. They can actually assess for their other medical, psychological, cognitive needs, and then functional abilities as well. A lot of like different teams that we will talk through later on in the communities that can actually help. And why it actually really matters for these patients. It's about their outcomes, their improving life and their quality of life that really matters to them. And it is always a patient-centered care. So thinking about these different aspects of their life, actually what we are aiming for, we are aiming for a good quality of life for them. And then this is always about the patient, what actually they are actually getting benefit from these things. So with this graph, you can easily see over a 5-year time period, if it is a fit man or a fit person who actually would have died only in 15% of them. But if it is a severely frail patient, then you can easily see the impact that actually nearly about 2/3 of them will be died in next 5 years. So this is a huge impact on the patient and also on the relatives and the families, and especially for us, huge impact on the health and social care as well. So this is one of the picture, very easy for the assessment for time up and go test. You can easily see what actually we can assess a lot of things from this. And also there are other indexes or other calculators that we normally use for assessment of how we can assess the gait as well. Like Barthel index is like 100 score of like other activities. And then this is important. What we are actually seeing is about their gait, their mobility, their balance, their cognition, and how they are turning up around as well. This is all important, and also how they are feeling while they're walking as well. Sometimes they are dizzy, sometimes they are very fearful of walking as well because they have got lots of falls that have been in their recent events. So it is always important to think about these things when you are assessing. So again, the picture of a frail patient that can see easily how many they are more risk of falls. They have got like significant cognitive impairment. Weight loss is an important one that is sometimes we usually forget about in these patients, and sometimes completely forgotten to ask as well. And then recurrent hospital admissions, that is one of the increased frailty markers as well. Reduced functional capacity. Then all these are actually contributing these patient quality of life as well. So think about these things when you are assessing any frail patient and what is important to them as well. Thinking about in a frail patient, definitely a lot of pharmacokinetics that we normally see with the medication related effects. They have got reduced renal clearance because of the chronic kidney diseases, other problems, and then sensitivity of their brain actually to a lot of like medications that we normally use, like benzodiazepine, phenothiazines, or we have got antipsychotics or antidepressants. So thinking about what are the priorities, is that the symptoms are more important for the patient, or is that the prevention in long term, how much life expectancy they have got, especially if you are using any statins or anything else for the long time prevention. And then it is important for us to think about whether the quality of life of the patient is important as compared to the life expectancy for them, or what exactly important to them. Are they really thinking about only few things now in the days when they have got only a few weeks to few months to live, and they actually have got lots of medication to take? What is their actually goal? So definitely in robust patient, preventive medication has more long-term benefit. But if you will consider any frail patient, then are they really important? Time to benefit may exceed life expectancy, a lot of risk of more falls, polypharmacy, then definitely function decline, then a lot of like chances of going to have more confusion and getting more delirious with these medications. So same is like statins that I was just talking about. Simply again, tight glycemic control, especially a lot of patients with diabetes type 2, if they are on insulin or if they are on multiple other medications for diabetes, is that really this is what they want, or sometimes this is the more effect of like hypoglycemia they actually suffer from. So do we have to think about what medication actually they need and then how we can stop. Same is like a lot of other medication that patients are being on for years and years, like antihypertensive medications, heart failure medications, diuretics. A lot of like antihypertensive medication they don't need when they are actually quite frail, when they are having dizziness, postural hypotension, whether they will actually benefit with these ones or actually they are getting more harm than benefit. So high risk of medication, always think about considering when you are prescribing to these frail patients, especially the sedatives, benzodiazepines, anticholinergic, always check the anticholinergic calculator, ACB calculator, so that you know that how bad these medications are actually for their cognition. Then antidepressant, especially if they are being on there for years and years, is there any chance that you can reduce and then simply stop after weaning off that medication if it is not really important then? And then thinking about antipsychotics, what are the side effects of antipsychotics actually they are having in long term as well? And opioids are very common for the arthritis medication. Sometimes they are taking a lot of opioids, getting constipated, getting more side effects with these medications. So again, thinking about postural hypotension in the patients who are taking multiple medications for their blood pressure as well. So sedation, most common side effect of a lot of medication. If you will read about the adverse effect of the medications, so many medications can cause sedation. So many medications can cause delirium, confusion, dizziness, orthostatic hypotension as well. And then anticholinergic burden, definitely thinking about immobility, confusion, and a lot of other side effects. If you read, there are a whole lot of side effects for these medications. Then thinking about polypharmacy, how many medications actually one patient, if they have got 3 or 4 conditions, how many medications they are actually. Normally, I see about 7 to 10 medication for these patients. So is that really they want to take that many medications? Or is that the goal of life is changed later on as well? And then thinking about hypoglycemia effect, what actually prone for these patients to having like more falls? Will they get actually the side effect of hypoglycemia and then they actually get really respond to that? Are they really in that capacity? If they are feeling dizzy, how they are going to prevent that dizziness, what are they going to do? And then long-term effects, definitely a lot of admissions that we normally see with the significant hyponatremia and with the hyponatremia seizures, and then a lot of confusion and delirium. So think about all these medications, what they're actually doing to the patient. The important part is always the medication review. Are they actually taking these medication? Are they really compliant with that medication? Sometimes with the dementia patients, if they are living alone, they don't have any other support. They don't normally take the medication. Sometimes they miss a lot of medications. So think about, are they really compliant? Then what are the side effects actually they are facing with these medications? Then always think about stopping or starting any medication if they need something to benefit from. Then important always is like from the patient point of view is life expectancy, and from us as well, thinking about, are they going to live in next 10 years, or are they going to have life expectancy of nearly 5 years more, or a year, or 6 months, or a month? So it is always better to have an MDT approach, especially with the community pharmacist or the GP pharmacist, along with the patient, relative, GP, and then thinking about the other special services that are in the community that can actually support with these patients as well. So step one, always think about what is the goal. So we always set our goals as well. So think about the patient goals as well. So think about what actually matters to them now when they are in the phase of like 80s or 90s or 100s. Identify definitely high or low risk medications benefits, sedatives, anticholinergics, along a lot of like duplicate medications, especially with the diuretics when we are starting. Sometimes patient is not only one single diuretic, they are on 2 or 3 diuretics. Review especially the preventative medication, especially in considering the long term goals for the patient. If they are on statins, if they are really care home resident, CFS score of like 7 or 6, and or sometimes they are bed bound and they are advanced dementia, are they really going to benefit, or are they going to really live long enough to have the benefit of statins? Then stopping or reducing one medication at one time and thinking about and discuss along with the family and the patient to improve like their quality of life as well, and thinking about what is their understanding of these things. And sometimes antipsychotic medications, I will say, and sometimes antidepressant medications, they are really important for the patient because they have been on these medications for so long. And then if we are completely stopping, sometimes they get severe withdrawal effects. Sometimes severe withdrawal effects lead to the admissions to the hospitals as well. So thinking about having a discussion, and then the pharmacist role is very important in these patients, and the psychiatry team as well. So take on board with the MDT approach, always think and discuss with them. And this is the more important process, like monitor and review the symptoms, especially with the blood pressure, especially with the postural hypertension. So always think about when you are prescribing or de-prescribing, is it still needed? These medications will provide benefit or they are more causing harm now. So thinking about these common target medications, especially with the benzodiazepine, anticholinergics, duplicate antihypertensive medications, tight control of the diabetes, statins, opioids. So tramadol we have just highlighted here because it is some of the medications in opioids that patients are actually on for some good time, and they feel that this is one of the medication for their pain, arthritis. But actually, if we have seen, it's a lot of like complications of the tramadol that we normally see in the patients if they are taking, and if they have got previous stroke or any other cerebral changes in their scans, then do try to avoid tramadol because it can cause low threshold for the seizures, and they do get seizures with these medications. So try to think about different medications to start with, like with the WHO pain guidelines as well, just to think about what else you can actually prescribe and whether actually they need it, and whether you can have a different mode of like other medication that like a pain patch or something, and something else that will help and benefit them. Again, antiplatelets and anticoagulants. I will show you a few other cases that way you will realize why anticoagulants have actually done more harm instead of more benefit to them. And then PPIs, that is very common one of the medication that I've seen. Most of them like are actually on long term for sometimes just simple regurgitation is started in early 30s or 40s, and since then they are being on these PPIs, and they seems like that they are helping them for something, but actually there is no other specific reason, no other duodenal ulcers, peptic ulcers, or no other significant GI bleeds that they need actually these medication long term. So think about reducing, stopping these medication, and thinking about why they actually are on it. So this is always very important one because most of the time in the clinics when I usually see these patients, especially with the falls, when a lot of referrals I usually get from the community and the GPs and from the district nurses and a lot of other community services, and especially when they come in with the falls, always they seem like they have been taking these medications. They do not want to stop these medications. So I always feel this is a very big challenge for us as a health practitioners, just to see and think about why they are always thinking about in that direction. If the family is concerned, then definitely discuss with them why they are feeling that they will get deteriorated. If they have actually concerns, what they actually you can tell them, what you actually can show them. So it's always a best decision of like shared decision making. Think about what is actually important for them, and always think about review these medication. If you are trying to reducing the dose, or if you are trying to stop it after weaning off, then think about discussions with the other psychiatry liaison team or with any other teams that they have started initially. So it might be worth discussing with the like MDT approach. So these are the common ones that patient always say that this medication I have been taking it for so long, and it is really a good one. So always think about, always tell them that this is not really a good medication for you because it is doing more harm. Like sometimes hyponatremia, it is caused by the SSRIs like citalopram or sertraline. And then I usually ask the patient why you have started these medication. And unfortunately, they don't, even can't remember why they have started actually. And since then, they've been on the same medication for years and years. And then we usually tell them this is a medication that is causing actually the problems now. So you have to think about in a different spectrum. And then always give them an option that if there are a few things that will help, and then later on, if we feel that you can have some other medication that actually can help you, can benefit, then we can always think about the restarting of medication. So few cases, just I have a quick discussion about few cases and think about what do you think about how these patients actually do. So 82-year-old female patient with a CFS score of 6, so moderate rate, and then thinking about having a fall, but fortunate not to have any fractures. Background of history of like diabetes, hypertension, osteoarthritis, insomnia. So guess how many medications you can actually think about of having this patient that she should be on. Like with the diabetes, probably one or two. Hypertension, I will say one or two. And then for arthritis, probably one or two again. And then for insomnia, I'm not sure what exactly insomnia is there for, like whether they have got like some problems with that they have been discussed or been seen by some specialist services or not, but possibly one or two medications. But actually, when you will see how many medications there are, 9 medications. So are you really surprised? Because a lot of medication, if I'll see this patient now having a fall, they're definitely causing a lot harm than benefit, including like amlodipine, ramipril, benfluthazide, metformin, gliclazide, again diazepam, amitriptyline. So you can name it, and I can give you the side effect that this patient will have it. Like with these amlodipine, ramipril, and bendro, they will definitely have postal hypotension. I can guess so. Then gliclazide, will that causing much more benefit in this age when she is not really that eating much, she's really frail. Will that be causing more hypoglycemia, more tight glycemic control? Yes, it will be doing. And then again, diazepam, is that really good when she's taking at night and she has to wake up in the night and to go for a quick washroom trip or toilet, and then in the night she fell because she normally falls in the night because there is no other support and she get more confused with like less lighting on in the night as well. So again, amitriptyline on the night, 25 milligram, quite good dose. What is the anticholinergic burden for these amitriptyline? It's nearly about 3. So 3 is the highest one. So you can think about how much cognition actually she will be having issues later on in the life. Then again, codeine, she is taking 4 times a day and sometimes extra on the PRN. And then again, favorite medication, omeprazole. Is there any indication for this omeprazole? I cannot see. Might be sometimes some heartburn in the past, and then since then she has been on it. So you can easily see how many medication actually you can review, discuss with the patient, and actually stop. So we go to the next case. Again, CFS score of 7, severely frail patient, care home resident, recurrent dizziness, 89, nearly 90-year-old with reduced mobility. Now you can see the other problems of the health, previous stroke, CKD stage 3, heart failure, atrial fibrillation. So you can easily guess at least 9 or 10 tablets again. Yeah, let's see. So I think my guess is fine, 10 tablets. So you can see apixaban, yes, definitely has got atrial fibrillation, previous stroke, so this is important. Bisoprolol, furosemide, spironolactone, so 2 diuretics, again for the same effect that we are trying to achieve. In this care home patient who has got frailty score of 7, nearly dependent with like bedbound or dependent for everything, is that really matters for her that she is on 2 diuretic medications? Will that be causing more benefit or dehydration or more harm? And thinking about statin, 90-year-old lady who has got life expectancy of nearly 6 months because she has got severely frail. And then is that really benefiting her in long term? Not necessarily now. Same is like oxybutynin, amitriptyline, sertraline. So again, if you will calculate with the acetylcholine calculator burden for these medication again, then you will see again that these are the high risk medications. So is that really we need? Again, zopiclone, again at night, so it is high risk for having developing delirium in the nighttime as well, high risk for falls. So this is actually how things change in the life and they are still on the same medications. So thinking about reducing medication, have a discussion in the MDT approach, discuss about the goals of this patient now. So all the emphasis now we normally think about frailty is influenced as much as the social context as the medical issues. Thinking about social isolation, poor limited support, and then poor housing, and a lot of things with these polypharmacy sits actually in these complex issues. So think about what we are actually achieving for these patients. So MDT approach is always better to have for these severely frail patients, including the GPs and the practice pharmacists, community and district nurses, physiotherapists, and then the social prescribing team, social services, and some other voluntarily sector groups as well. That like aging that they do have like befriending services and a lot of other services that can actually help them. So similarly, identify the non-medical needs early and then think about these patients with the best community support that they can get. MDT approach for these complex high-risk patients. And if you feel that they need benefit and they will get benefit from review by the geriatric team or the community virtual team or community geriatric team, then do please refer these patients to the hospital services as well. So this is one of the anticholinergic drug burden calculator that you can easily use in your practice. And it is very good one because you can easily see the common medication that we normally use. So thinking about atenolol beta blocker risk score is 1, so it's still pretty good for us to use. But if you will go on to risk score of 3, and if you will go on to more high risk score, then there are more risk of having the cholinergic toxicity. So you will see easy ones like oxybutynin. A lot of our patients are actually on oxybutynin because of the incontinence issues. Amitriptyline, from the pain up to the depression up to anything else. They are most of the having been on this for so long. Tricyclic antidepressants, especially the citalopram and the sertraline, very common one. And then think about these medications, especially with the chlorphenamine and other sedative medications as well. So thinking about antihistamine, sometimes they are on actually for dry and itchy skin for so long. Are they really actually need that? Instead of that, can they have a moisturizer for their skin and avoid these medications? So these are some of the hospital actually admissions, real patients, but different names, and some of the things that have changed because of slide presentation, but they are actually actual patients. So Doris, 88, who has come in from the care home, working with the frame, definitely needs a lot of supervision for her ADLs as well. And then background, again, ischemic heart disease, 3 medication, statin, bisoprolol, isosovir mononitrate, atrial fibrillation, then definitely on DOAC as well, CKD on ACE inhibitor for secondary prevention. Let's see. She started with a mild cognitive impairment. She fell and there was no head injury, but she had a hip fracture. And that is a life-changing event as well. So she had the surgery the next day, uneventful surgery, but actually she stayed in the hospital for at least 2 weeks. Normally, it is 3 to 5 days. The patient should be able to go back to their normal activities if they are quite fit and robust. But if they are frail and severely frail, in this case, then definitely they stay more longer in the hospital. They developed hypoactive delirium. She developed later on hospital-acquired infection like pneumonia. She had the constipation because of the opioids she had because of the pain, and the new catheter started. So a lot of things changed during their hospital admissions. But during her admission, we have stopped a lot of medications as well, like isosovir mononitrate, bisoprolol, statin. A lot of these medications were not needed because she had massive postural drop that we noted during the admission as well. And then advanced care planning is always important. So thinking about do not resuscitate discussions and always having the further discussion about the respect and advanced care planning. So she was discharged to care home after 2 weeks of hospitalization, and she was really a fortunate one that she was more well after that, and she was still walking with the Zimmer frame. So another example of Catherine, she is 92-year-old. She was admitted with the fall and collapse, and definitely she was found with the fireplace unconscious by her neighbor. She was assessed in the hospital. She found that she was having quite low blood pressure, and she was on bradycardic on resuscitation cardiac monitor. And then definitely she was admitted under us because she was 92. She was having bradycardia and she was quite frail. Long, again, list of medication: hypertension, heart failure, angina, depression, anxiety. Again, medications, the common one, you can easily see citalopram, spironolactone, 2 diuretics, statins, antiplatelets. So again, polypharmacy here. So admission, definitely investigation, history, and most important is comprehensive geriatric assessment that we usually do with all the patients. So with these medications, what do you think what we have done then? Definitely when we have done the ECG showed that she has got a complete heart block. So we stopped her by bisoprolol. We stopped other medication because of the postural hypotension as well. And then she had a reduced dose of furosemide that because she was still needing for her heart failure. She was reviewed by the cardiology, and then eventually she was discharged later on with a package of care for the home and reablement services. But it took for at least 6 weeks for her to be in the hospital. And another example of John here. So 79-year-old, and he was admitted with recurrent falls, and he sustained a pubic femur fracture. Previous history of chronic kidney disease, hypertension, diabetes, vascular dementia, and a TIA as well. Normally, he was living with his wife, who was supporting a lot of other activities for him at home, and he was still walking with a walking stick and sometimes started using the Zimmer frame. He was stopped driving because his memory was worsening. Medication list: statin, aspirin, and losartan, calcium channel blocker, calcium vitamin D supplementation, and he stopped oral bisphosphonate recently because of his upper GI upsets, and he has previous fracture. So what you are going to do next? Definitely examination history, comprehensive geriatric assessment. So ECG did show that he had third-degree heart block and causing him to have the pauses and having the falls. So he had a discussion with the cardiology team. He had the pacemaker fitted, then did his scan of the head because he was getting funny episodes with dizziness, confusion. He was more delirious. So it showed a small subdural or subarachnoid hemorrhage. So what else we can think of, like whether it has got some more changes in the brain. And then the next investigation we did was the MRI. And it was something different on the MRI because it was not there a lot on the CT head scan that showed. So this is MRI scan that has got shown small bleed here, a lot of small bleedings around as well, and some ischemia around. So it is very common that we normally see in our patients has got like very few findings on the CT scan, but they actually have got more findings on the MRI if you are suspecting any other conditions. So this is called cerebral amyloid angiopathy. So he has new diagnosis of amyloid angiopathy as well. He had a pacemaker. We stopped aspirin because he had more high risk of bleeding, and especially with the falls that he was sustaining. He was discharged home with some community physiotherapy, definitely advanced care planning, DNA CPR discussions, and memory services. And then his hospital stay was nearly 3 weeks. So another patient called Kumar, 94 years old. He had a fall, tripped, head injury, came into the hospital, background of hypertension, CKD, and atrial fibrillation medications. Again, you can see the huge list there. Comprehensive geriatric assessment showed that he was mildly delirium. He was still having some headaches, and the rest of the examination was fine apart from his atrial fibrillation that we were aware of. So bloods were fine, reasonably fine, and X-ray did not show any refracture. And then CT had as part of ongoing fluctuating delirium and head injury. So we thought might be there is something more to add because he was also on DOAC. So this is his scan with the CT head, and it is actually the scan of this patient. And he had this bleed that you can easily see. It's all the subdural hematoma that has got a midline shift. And along with that, his GCS was still fine. He was still alert, but he was very wobbly on his feet. He was having a fluctuating delirium. He has massive systolic blood pressure drop, and he was very symptomatic with the postural hypotension. So medication again, what do you think what we have to do? Again, we have to think about stopping the medication that is causing postural hypotension, discuss with the neurosurgeon about this subdural bleed, given some Octaplex, stopped his DOAC, and definitely he was more stable, transferred to the neurosurgeon for drainage of this subdural hematoma. And then he was referred back to us after a week of hospitalization with the surgeons. And then he was discharged home with actually some support with the physiotherapy. And he's still doing really well. I usually follow him up in the clinic now, and he's still fine, but his memory is not as good. He's just having more deterioration in his memory. So I usually see in the falls clinic, I will say from 5 out of 4 patients has got postural hypotension. And it's a really major worry now in elderly patients, especially a lot in hospitalized patients as well after having a falls. And think about medications, how many medications they are on, how many medication side effects actually they are having. So if we will review these medications, can actually save them to have the hospitalization, and also always look for polypharmacy. So these patients are having a really low reserve. So think about the frailty in all these patients when they are falling. Think about the bones as well. So bone health is very important in patients who are having actually falls. So I usually always assess them for osteoporosis as well. If they have sustained any fragility fracture and they are having more falls and they are more prone to have falls, then definitely think about what actually they need for future for their protection of a major hip fracture or major spinal fracture and other fractures as well. So some more examples that we normally see, statins that normally prescribed with clarithromycin. So think about level of statin. It increases the level of statin, it causes hepatotoxicity, it causes myopathy. Long-term steroids, I have just one patient that actually discharged home with some physiotherapy. He came in with the falls and he was being on long-term steroid because of his renal transplant. And he's been on steroid for nearly 60 years. So you can imagine how much myopathy he will have from steroid. So risk of adrenal insufficiency, always think about these patients when they are having falls. And always think about the sick day as well. So double their dose of their steroid during the acute phase of the illness as well. Again, DMARDs for that we normally use for rheumatoid arthritis patients. So immunosuppressive effect of these medications, thinking about omitting in the acute infection when they are having, always think about discussing with the rheumatology if they need to. Some more examples like methotrexate and trimethoprim, sometimes we commonly give in the urinary tract infection for these patients. So what they actually do, they both reduce tetrahydrofolate, and that is causing decreased drug inhibition. Like these drugs basically inhibit DNA synthesis and bone marrow suppression in actually acute setting as well. So think about these medication when you are combining or giving to these patients. Another one, very interesting one that we normally see a lot of in our heart failure patient, Entresto. You might have seen a lot of your patient as well. So it has got significant effect on these patients if they are really frail, especially if they are on this medication, can cause significant dehydration, AKI, renal failure, hypotension. Similarly, if the patients are actually taking codeine, sometimes patients they get accumulated in the kidney failure patients. So think about switching codeine to other medication like oxycodone if they really need to. And especially sometimes patients are actually on these two medications, very common combination of codeine and loperamide. And it can cause severe constipation that I have seen a lot of patients who are having some overflow diarrhea and they are prescribed with loperamide and then they get constipated and then overflow diarrhea and then on the top they are getting loperamide. So you can imagine what actually we are treating them. It's hard for us to see how much we are actually giving the benefit. So thinking about medications, always think about medications to avoid admissions of the hospital. If you can review these patients in the community, definitely they are worth having discussions with the community, other teams like we have got in our setup, like e-consultation that the GPs, community nurses, and advanced care practitioners, they actually discuss with us as elderly team, and then we can always advise on these medications or other options of investigations if they need to. Similarly, it's like early review of these patients in the clinic, outpatient settings, and sometimes virtual ward or hospital at home teams. Actually, they help a lot in these patients from the setting, stepping up or stepping down from the hospital. And then it feels like us, it's a bridge services that we usually use between us and the primary care as well. Thinking about respect discussions, I'm aware that it's a lot of like discussions happening anyways now because a lot of people are aware of these frail patients and then they do have discussions. Medications, definitely thinking about in the community setup with the community pharmacists about at least in a month time or when they are having the repeat medications, are they actually needing these medications long term now? Or also thinking about how we can avoid these hospital admissions and being treating them in the community. So gold standard framework, always think about these and end of life discussions, fast tracks. These are the discussions that actually patient can have in the community and then thinking about what actually their goal in the last phase of the life. So this is the advanced care planning, thinking about in the frail patient that is always benefit with them, thinking about discussions with them at earliest possibility and discussion with their family and the carers as well. So early recognition management of frailty is always important, and it's always important that always try to do the comprehensive geriatric assessment with these patients, and especially advanced care planning is really important in order to severely frail patients so that you can avoid these hospital admissions and they should have their own plan what they are actually want to have in their last phase of life. Medication review is always important. So think about whenever you are seeing the patient, are they really need these medication? Is actually benefiting these medications or they are getting more harm? Patient wishes are always matter because they are the main person who are actually getting these medication and getting the side effects. So think about medications and the patients, what their goals and the wishes are. These are again the frailty markers, loss of muscle mass, strength, and the function key indicators. Always think about discussing frailty and the other problems that they are facing. Use these hospital avoidance team as a community bridging team as well. So hopefully this will help you and us as well in guiding the right direction for the patient treatment and the final goals. So this is all from my side. If there are any questions, I'm happy to answer.
Thank you very much, Dr. Guri, for that really informative presentation. We have got a few questions in the chat, if that's okay to go through. So the first one is from Robert. Would you include the gabapentinoids in the high-risk drugs, so pregabalin, gabapentin, drugs like that?
So it is always have a like MDT approach for these patients as well. If you feel that the patient is already on multiple other analgesia for their certain conditions, is that the gabapentin actually really helps for their polyneuropathy or not really? So it depends what is the patient goal and what other medication they are actually on. If they are on like amitriptyline or other anticholinergic drugs, then definitely gabapentin will add on more burden to them. So think about other aspects of the medications as well, and think about other analgesia that you can offer. If it is really necessary, then you can always start with a lower dose medication and think about like getting into like a discussion with the pain team, sometimes really important, and they can give you actually other options as well.
Yeah, for me, if I could just add to that, so in your clinical practice, if you've got someone elderly that is in chronic pain, what would be your sort of first go-to drug to help that? Sort of bearing in mind what we're saying about about de-prescribing, but sometimes you need to prescribe. So I just wondered what's your starting point really for those patients.
So chronic pain depends what exactly the chronic pain is actually from. If it is really a polyneuropathy pain and they are suffering because of the neuropathy, then definitely gabapentin is a good choice. But gabapentin and pregabalin, they are two different ones. Gabapentin is like you are giving them 3 times a day. You cannot reduce to 2 times. You have to give at least 8 hourly. The other medication, pregabalin, is actually twice a day, and you can start with a low dose medication, pregabalin. I usually prefer pregabalin to go for if you are really in need of starting because it's twice a day. It will reduce the number of the tablets for them as well. And then try to titrate up according to their benefits, how much they are getting and how much side effects actually they are getting.
Oh, thank you. Thank you. And we've got another question. It's what do we do for people with small vessel disease on CT scan if they've got no previous MI and managed hypertension, etc.? And would you start someone on aspirin if you found that finding on a CT scan?
So it again depending on why. First of all, the thing is like why you have done the CT scan. Is that the frailty that you are really worried about, or is that the recurrent falls they are having, or is that the memory you are thinking of that they are having the problems with the memory and cognition decline? Then definitely it's worth always thinking about starting on secondary prevention. But again, the time is like important for them. What is their life expectancy? Are you thinking of they are going to live for another 5-10 years? Then definitely the benefit of aspirin will be there. But if they are having high risk of falls, severely cognitive impaired, then it is not really benefiting them. But yes, a small vessel ischemia, when you see if there are any risk factor underlying hypertension, diabetes, peripheral vascular disease, then definitely it is worth trying giving them aspirin.
Thank you. Yeah, for me, I suppose, reflecting on my practice, that there's certain drugs that I'm quite confident in stopping, but there's other drugs that I worry about. So, for example, about, and I know that you're saying stopping things like beta blockers and diuretics for patients in heart failure. And I suppose my worry is that by doing that, I might inadvertently put them into crushing heart failure and precipitate an end of life event or something. So, that's my anxiety really on deprescribing those drugs.
If they are getting any side effects of the beta blocker, then definitely worth trying reducing the dose or switching to something different. It's always better. If they have got previous MI and ischemic heart disease, beta blocker is the mainstay of their treatment. So we normally keep them on a low dose because the actual problem is like some of the beta blockers, they can mask the hypoglycemia effect in diabetes patients. So sometimes we do see these patients get hypoglycemic episodes whether they are not aware of the symptoms. So sometimes it is important to think about and always have a discussion with the heart failure team or with the cardiology team. If you are really suspicious of like stopping and thinking of like they might not really get benefit or they might get really back into the heart failure again, especially with the diuretics. Sometimes we do see them on 3 or 4 diuretic medications for the same reason. So it's not really worth trying 3 or 4 medication, but actually titrating one medication to get a maximum benefit for them. And then thinking about adding on like potassium sparing or like Entresto. Entresto, I've seen like in a lot of our patients that usually get admitted with AKI and severe kidney failure. So sometimes these patients are not really, they have had the cohort of these heart failure patients that they can start actually Entresto on, but these are the patients who are really actually fit and well with the heart failure, not our severely frail patient who has got other loads of like medications and they are severely frail with getting a lot of side effects of other medication anyways.
Thank you. Thank you. So I don't think we've got any more questions. Anyone else got any questions they want to put their hand up or come on? If not, we might have a bit of an early break. So we've got Ruth.
Yeah, I think I put the question in the chat.
Oh, right. Sorry, did I miss one, Ruth? Sorry.
It was about DOACs and stopping them and the short-term sort of increased risk of thromboembolic events, because we've had 2 patients, both in their 90s, who we have had a discussion about stopping a DOAC with. One had persistent hematuria, which had been investigated and no cause was found, but it was very distressing. And another one had had a couple of falls and it was felt to be too high risk to stay on the DOAC. And they both, within a week or 2 of stopping the DOAC, had strokes, which weren't major strokes, but they did have an impact on their quality of life. Is there anything that can reduce that risk of that short term stopping the DOAC where the thromboembolic risk does increase, to prevent that from happening?
This is a very good question because I usually see a lot of our patients as well when they are coming into the hospital having major bleeds or sometimes not bleeding, but like other problems with the falls, and they have got like issues with these medications like hematuria, especially in the patient who has got the bladder cancers. So it's always very hard discussions with them. So it's always worth trying to give them the benefits and the risk of the medications. And sometimes families, they play a really important role because the patient, sometimes they don't have capacity or sometimes there are difficult decisions that the patient cannot take on their own. So it's always worth trying having a multidisciplinary approach and discussions with the other teams as well, giving them the fact that they will have a stroke or TIA in the future. If you will stop, definitely that's a risk. But is that the risk of having a stroke or is that the major bleed with the fall that is actually causing the life expectancy to be going down very quickly? So it depends what they actually feel with these patients about. So sometimes we have to stop, and then given the risk of having a stroke, they have to accept that risk. So it's
and then they
very
end up
hard
back
discussion.
on the DOAC.
Yeah, sometimes it is hard discussion. Sometimes patients do actually, they feel that they need to carry on, even though they know that these are the side effects of the drug they're actually having. But sometimes these are the sometimes difficult decisions that we have to take. And we always discuss with the stroke team, and then we think about like this is causing these problems, and we think that we need to stop. And then it is like instead of one clinician, we do have like 2 or 3 clinicians, the same question answering same approach, then definitely it's really worth trying with having like other teams as well.
Thank you.
Thank you. And we've got Santaya. Do you want to put your camera on?
Sorry, my camera won't work.
It's okay.
Sorry about that, Dr. Chaudhary. Thank you so much, Dr. Corey. I had put a question. I don't know whether it was answered. I got a bit distracted in between. That was for
Is that the question about the frailty explanation to the patient? Is that your question? Or
yes.
No?
And if we can give anything else to them.
Is that the question with the small vessel ischemia? Is that we have answered, or?
Thank you. If it has been answered, thank you so much. I'll just listen to the recording again. Thanks, Dr. Corey.
It looks my chat function, it says it needs refreshing, so I might, after at the break, I'm going to come out the meeting and come back in again, because I'm no good helping facilitate if I can't see the chat. So apologies if anyone else wants a question, because I can't see it. If you want to just shout up.
I think there is a question. It's actually about the same, that we normally see a lot of medications, overuse of regular in frailty as well, which often causes dehydration, falls, electrolyte imbalance as well. So that this is very common, that we normally overuse medications as well. Treating duplication of the treatment, duplication of the medications, this is very, very important for our patients as well. So I always take the approach of like discussing, even like single medication when the patient is taking, I always ask them why you're taking this. And I've just seen this morning one of our patients from a community, and they have referred because of the falls, and she came in, she is 98 years old, and she's still very independent. And you can guess that she was, how many medications she was on. So she was not on even single medication. And I was so happy to see that lady, and she is so proud. And she told me like, I'm so happy that I'm not on any single medication, because I don't believe that medication can help me a lot. I usually believe in other things that can help me a lot. So she had nothing to do with the postural hypotension. There was no medication. She not had any postural hypotension. Then we checked, and her time and go test actually was really good as well. It was, I think, nearly 12 seconds, and she was quite robust. So I was just like, why are you having then falls? And she was like, I think I tripped, and that is all. And there was nothing else that I can actually do or prevent or help. So I was just like very glad. And I said, it was her birthday as well. So I was just like, happy birthday. And I think you are going to live another 10, 20 years. And I will see you again in the clinic. Hopefully not, but might be. But I'm really happy and really glad that you are not even on a single medication.
Yeah, thank you. That was really helpful, and thank you for answering the questions. Is there anything else? I can't see the chat, Louise and Dr. Gori. Is there anything else in there?
So it's like about discussing about the frailty and most difficult things actually to explain frailty to the patient and the families. Definitely, it's a very good thing that we normally face, but like it's a big challenge for us. But I always take this challenge as a really open approach, and I always discuss with them like what actually frailty means, and I always find out what exactly it means to them. If they feel that this frailty is just only like some medication that we need to stop, or is it actually they know what exactly it is causing overall effects. So I always discuss with them in more details about these things, that medications, their walking, their mobility, their other problems like cognition, their other functional ability. It's always included in these assessment that we assess, and always include them, their families as well, when I'm discussing about frailty. So always give them some reading information as well. It's always helpful for them to read in their own time, to think about what actually matters to them now. When they usually come back to have the second consultation, I always discuss with them and find out what actually they want now. And their spectrum of like thinking, it's completely changed later on, because they now think about what actually matters to them. It's not about what actually matters to their other family members or other things that they feel, but actually they start thinking about what actually matters to them. And this is really important, giving them that opportunity and that sort of like importance, so that they can think about what actually they want to get us doing for themselves.
Thank
There's
you,
a hand up.
Maurice.
I've got a question about postural hypotension. You find sometimes you have elderly patients with postural hypotension and they're on antihypertensive, but their blood pressure is still high. How would you approach that?
So always check the blood pressure, what time it is actually high. Is it early morning it is high, or how high it is actually? If I see any failed patient whose blood pressure is around 140 and 150, I will say this is fine for them. I will not tightly control their blood pressure then. I will leave that out. Because if they are suffering more with the hypotension, then it is better to treat hypotension instead of hypertension. Sometimes we do give medication in a different time periods. So I always ask my patient just to get a diary and write down their blood pressure readings in the morning when they wake up without standing, and then before going to bed and in the middle of the day. And I usually see it as spectrum. Or sometimes it is important that we usually get 24-hour ambulatory blood pressure monitoring for these patients and think about which time they actually need some medication. Sometimes medication before going to bed really helps. And then having an early morning full glass of water next to their bed, it is important as well. Then we always think about any other medications that we can think of stopping, reducing during the daytime. And can actually they drink about 2 liters in a day or more than 2 liters? So it's about how we are taking the approach of the postural hypertension and hypertension together. So it's always, everyone is different. I have seen patient who has got systolic blood pressure only in the night time. So I usually give only small dose of any hypertensive medication before they go into bed. And early morning, again, they have got massive postural hypertension. Definitely there is not much we can do apart from like trying other TED is stocking, compression is stocking, sometimes abdominal binders that we have tried as well. So different things that we can do, and then sometimes fluorocortisone or midodrine for their postural hypertension during the daytime, and at the nighttime small dose of any ACE inhibitors or a beta blocker or something that they already have been on, but a small dose.
What about if you've got postural hypotension and then you have stopped all the medication and you can't find any identifiable cause? When would you start to consider giving them fluorocortisone? That's another, sometimes that can be a bit challenging for me in terms of when should I start fluorocortisone?
So always try to find out the reason of postural hypertension, what is actually causing the postural hypertension. Is that their lifestyle is not really accurate, they are not drinking that much fluid that they should do. So I always go from the fluid intake first, then thinking about decaffeinated drinks as well, then thinking about building up onto medication side. If their postural hypertension was secondary to other medications that you have stopped, then definitely they should improve. If they are not improving, just to think about other reasons as well, whether there is any other element of autonomic dysfunction. Sometimes we do see patients with the postural hypertension with autonomic dysfunction as well. So approach is different, but then you can always think about starting fluorocortisone when you feel that patient is really well hydrated, they can actually drink that much fluid and they are doing it, decaffeinated drinks, everything is there. But despite that, it is not helping, then definitely you can always try starting low dose of fluorocortisone, build up to that.
Thank you.
Thank you. So I think unless there is any more urgent questions, we probably should bring this first session to a close, so to give everyone a chance for a comfort break. But thank you again, Dr. Gurry, for giving up your time this afternoon to join us. It's a really informative talk, and I'm sure it's given us food for thought for our own practice on being proactive again about medication in frailty. So thank you very much for that.
Thank you so much for being listening all that talk, and I hope I'm not too fast, because most of the time I'm too fast.
Thank you.